Awesome. So it looks like a ton of people taking it in July. A few people taking it in October as well. So good. Hopefully for everybody taking it in July, we can get you really up to speed on some of these topics here. But great. Good luck to everybody, especially those taking it in July. It's tough. It's a tough exam, but I think, prepare well and you'll do well. So let's go on to just quick introduction about me. So like I said, my name's Dr. Mike Crowell. I'm currently an associate professor at the University of Scranton, where I teach their orthopedic content. I'm also one of the authors of the Therapy Ed NPTE Review and Study Guide, where I'm primarily responsible for Chapter 2, which is the musculoskeletal content. My background, I recently retired from active duty as a Lieutenant Colonel Army officer. I've got 18 years of experience in orthopedics and sports. And I just left West Point as the fellowship director for the West Point Division I Sports Physical Therapy Fellowship. Throughout my career, I've had a variety of clinical and leadership roles. Some of them you can see there, I had a little bit pictures on the right. So for the West Point Fellowship, I was actually there for 8 of the past 10 years. That's that picture from the bottom left. I really enjoyed teaching my fellows there. Spent half that time as the program director and half the time on faculty. I was also at the Office of the Army Surgeon General, where I participated in a health and wellness project called the Performance Triad. So a really great experience there in more of a health and wellness setting. Um, I deployed as a brigade physical therapist with the 101st Airborne Division, and that is pictured on the top right there. That was what my kind of clinic looked like. That's me working on one of my patients. And it also had a little bit of a unique career. You can see a picture in the top middle there. I started off as a field artillery officer, and I was stationed in Bamberg, Germany. All right, so let's move on to tonight's topic, which is the clinical practice guidelines for the hip. So the major objectives here, we're going to discuss the guidelines for both the hip OA and then non-arthritic hip pain. And then we're going to answer and discuss some simulated national licensure exam questions in the areas of exam, evaluation, and intervention for both of those. One thing to point out, you're going to see on some of these slides bonus content. This information is probably above and beyond the clinical practice guidelines. It may not be directly tested on the exam, but it's definitely going to provide you with additional depth and context, which could help you answer questions on the exam and is going to be useful in clinical practice. What you're going to see on a lot of these exam questions when you get to taking the NPTE, a lot of them are vague. You're not going to really know what the correct answer is 100%. So I think the more background information that you have, the better that you'll do on some of those questions. So now let's look at content. So as you can see from this chart here, when you look at musculoskeletal, it's the biggest part of the content area for the exam, 27%. And now if you look a little bit differently at the main kind of focus areas, so the 3 main areas that you want to focus on, examination is 1, evaluation, differential diagnosis, and prognosis is 2, and then intervention is 3. And so why CPGs? I think one of the things that you can think about is that, these are big documents. They've got a lot of evidence base that goes back many years. So a lot of it's likely to appear in your textbooks, which is where the exam questions all come from. And these things are really just a one-stop shop for all those 3 major areas of a topic. So you're going to get exam, you're going to get evaluation, you're going to get intervention, all in one kind of quick and easy document to look at. So when we look a little bit closer here, so again, musculoskeletal, 27%. If you look at the examination portion, that's 24% of the musculoskeletal content, or 24% of the overall content. You could see anywhere from 14 to 18 questions on the exam for that. As far as evaluation, you could see 15 to 18 questions, and intervention, 15 to 18 questions again. So overall, on the big exam, you're looking at about 44 to 54 questions on a musculoskeletal topic. All right, so now before we review the clinical practice guidelines, let's briefly review the relevant anatomy and the biomechanics of the hip joint. So the hip is formed by the articulation of the femoral head and the acetabulum. Femoral head is 2/3 of a sphere, oriented superiorly, anteriorly, and medially, and it's covered by articular cartilage. The femoral head is connected to the femoral shaft by the femoral neck, with the neck as what is called the angle of inclination, which is normally 115 to 125 degrees. Coxa valga is an angle that's greater than 125 degrees. while coxa is an angle that's less than 115 degrees. The femoral neck angles anteriorly 10 to 15 degrees from the frontal plane, which is called anaversion. And then the excess anaversion is an angle greater than 25 degrees, while excess retroversion is an angle less than 15 degrees. The acetabulum faced laterally, inferiorly, and anteriorly. And unlike the femoral head, it's not completely covered with cartilage. Its cartilage is horseshoe shaped with a gap anteriorly forming the acetabular notch. There are three main ligaments of the hip joint, which are very strong capsular ligaments. The iliofemoral ligament is one. It's a very strong anterior ligament. It forms a Y. Both of these bands tighten with extension and external rotation, and then the superior band tightens with adduction, and the inferior band tightens with abduction as well. The pubifemoral ligament is also anterior, and it restricts extension, external rotation, and abduction. And then the ischiofemoral ligament is posterior and becomes taut with internal rotation, abduction, and extension. Now the acetabular labrum, this is a triangular shaped and is triangular shaped and it's composed of a fibrocartilaginous ring. It's thickest superiorly, which makes sense because of weight bearing, and then it attaches to the bony rim of the acetabulum. The labrum functions to deepen that acetabulum. The joint capsule is strong and dense and encloses the entire joint, very, very strong. And of note is the zone of weakness in the femoral neck, where the trabeculi are relatively thin and they don't cross each other. This can be an area of concern with regard to bone stress injuries, particularly in long distance runners and military recruits. The muscles of the hip make their most important contribution to function during single leg weight bearing to stabilize the pelvis and the trunk. The muscles that produce hip flexion, there are the iliopsoas, the rectus femoris, the tensor fasciolata, and the sartorius. The rectus femoris, as a muscle that crosses two joints, also produces knee extension. The sartorius is also a two-joint muscle. It produces flexion, abduction, and external rotation of the hip. The muscles that produce hip adduction are the pectineus, adductor brevis, adductor longus, adductor magnus, and the gracilis. And the muscles that produce hip extension include the gluteus maximus and the hamstring muscles. So remembering that the hamstring muscles from medial to lateral consist of the semimembranosus, semitendinosus, and then the long and short head of the biceps femoris. They also cross both the hip and the knee joint and produce hip extension in addition to knee flexion. The hip abductors have been termed the rotator cuff of the hip, with the gluteus medius and minimus being analogous to the supraspinatus and subscapularis muscles. The gluteus medius and minimus function together to abduct the femur, or more importantly, to stabilize the pelvis and the trunk when we're doing single leg stance. There's 6 short muscles whose primary function is to externally rotate the hip, and they're the obturator internus and externus, the gemellus superior and inferior, the quadratus femoris, and the piriformis muscle. There's no muscles with a primary function of hip internal rotation, although the anterior portion of the gluteus medius, gluteus minimus, and the tensor fasciolata do contribute some to this movement. And then the adductor muscles likely also produce some degree of hip internal rotation as well. The hip joint, as we know, is a ball and socket synovial joint. It allows movement in 3 planes. So we have flexion extension in the sagittal plane, abduction adduction in the frontal plane, and internal external rotation in the axial or the transverse plane. Normal ranges of motion are 110 to 120 degrees of flexion, 10 to 15 degrees of extension, 30 to 50 degrees of abduction, 30 degrees of adduction, and 40 to 60 degrees of external rotation, and lastly, 30 to 40 degrees of internal rotation. The resting position of the hips, 30 degrees of flexion and abduction with a little bit of external rotation. And the closed pack position is full extension, abduction, and internal rotation. The capsular pattern, which is frequently seen with things like hip osteoarthritis, is a loss of internal rotation and flexion. And normal gait requires at least 30 degrees of flexion, 10 degrees of extension, 5 degrees of ab and abduction, and 5 degrees of internal and external rotation. All right, so now we're into the meat of tonight's topic, which is the clinical practice guidelines. And we got a couple of them here. We're going to start off with hip osteoarthritis. We have a older initial document, and then primarily most of what you'll see tonight is coming from the 2017 revision. So hip osteoarthritis, most common cause of hip pain in older adults. The prevalence rates of hip pain in older adults ranges from 0.4 to 27%. The most significant risk factor for the development of hip OA is age, as the condition primarily occurs in middle-aged and elderly adults. And age is significantly associated with hip OA. So with an adjusted odds ratio of 1.3 in those 60 to 64 and 2.4 in those age 65 and older. And what that really means to you is that those age 65 and older have a 2.4 times greater odds of having hip OA compared with those younger than 60. Developmental disorders also increase the risk of developing hip OA. So some of them like leg calf Perthes disease and slip capital femoral epiphysis are two conditions that may cause premature OA. Hip dysplasia, which is defined as any change in the orientation of the acetabulum or proximal femur, also increases the risk. The types of hip dysplasia may include coxa-vara or valga, femoral anteversion or retroversion, acetabular anteversion or retroversion, or coxaplana or profundus. As in most other joints, any previous injury may create abnormal joint load bearing, which increases the risk for developing OA. So the odds of developing hip OA is 4.3 times higher when you've had a previous hip injury. Reduced hip range of motion, higher BMI, and elevated bone mass also increase the risk of developing hip OA. Now, while the natural history of individual hip OA is not well understood, there are some common features. Peri and intra-articular changes include joint space narrowing, contracture of the joint capsule, flattening of the femoral head, and development of subchondral sclerosis or cysts. And then the extra-articular changes include decreased joint range of motion and muscle weakness. Those with cam deformities, which is a form of femoral acetabular impingement, which we'll discuss later in this presentation, develop hip OA more rapidly. So a high-quality examination of the hip is going to combine key information from both the subjective and the objective portion. So as I discussed earlier in the risk factors, patients with hip OA are typically older. They frequently report moderate pain in the anterior lateral hip, particularly with weight-bearing activities. Pain may also be referred to the anterior thigh or the medial knee region. Patients with hip OA may complain of joint stiffness in the morning, which is improved usually within 1 hour of waking up. The most commonly used outcome measure for hip OA is the Western Ontario and McMaster University Osteoarthritis Index, also known more commonly as the WOMAC. It's been shown to be valid and reliable in many studies. It consists of 24 questions, 5 about pain, 2 about stiffness, and 17 about function. A normalized score would range from 0 to 100%, with higher scores indicating greater disability, stiffness, and pain. The lower extremity functional scale and the Harris hip score, they could also be used to evaluate patient self-reported function. And then the visual analog scale is used to assess pain, although in clinical practice, we more commonly use the numerical pain rating scale. Physical performance measures assess patient function and progress with rehab. And so we have the 6-minute walk test, the timed up and go test, the self-paced walk, and the stair measure that have all been utilized in patients with hip OA. In patients with hip OA, it's important to assess passive range of motion, particularly internal rotation, external rotation, and flexion. Hip range of motion measurement is reliable, with a minimum detectable change ranging from 7 to 11 degrees within all the planes of the hip motion. Hip muscle strength is also very important, particularly the hip abductors. So manual muscle testing when you're using a handheld dynamometer is a reliable measure of hip strength with a minimum detectable change of 28 newtons for the hip abductors, 31 for the hip extensors, and 7 newtons for the hip external rotators. Some useful special tests in hip OA include the Faber or Patrick's test and the Scour test, and we'll discuss more elements of the physical exam in some subsequent slides here. But before we discuss the diagnostic accuracy of special tests for the hip, let's review the definitions for sensitivity, specificity, and likelihood ratios. Sensitivity is a test's ability to obtain a positive test when the target condition is really present, or it's a true positive, and we use the mnemonic SNOUT. So a sensitive test that is negative helps us rule out a condition. And the formula is a true positive divided by the true positives plus the false negatives, or A over A plus C in the 2x2 table that we have over here. Specificity is a test's ability to obtain a negative test when the condition is really absent, or a true negative. And we use the mnemonic SPIN, so a specific test that is positive helps us rule in the condition. And then the formula for specificity is true negatives divided by the false positives plus the true negatives, or D over B plus D, based on our 2x2 table over here. However, there is a weakness to sensitivity and specificity, and it's that they are influenced by the prevalence of the condition. And so likelihood ratios tell us the probability that a patient has the condition after the test is done, and these are independent of disease prevalence. And you can see the formulas there, where a positive likelihood ratio is the sensitivity divided by 1 minus the specificity, and then a negative likelihood ratio is 1 minus the sensitivity divided by the specificity. Tests with small negative likelihood ratios should be utilized early in the exam. They're going to help you rule out alternative diagnoses. And tests with a large positive likelihood ratio can be used later in the exam to rule in a primary diagnosis. So let's use an example nomogram here on the right. Let's say we have a condition with a pretest probability of 30%. So if you have a negative test and a test with a negative likelihood ratio of 0.2, now your post-test probability after having done the test that they actually have whatever it was you were looking for is 5 to 6%, somewhere in that range, give or take. Alternatively, if you have a positive test result and a test with a positive likelihood ratio of about 3, that's going to yield a post-test probability of almost 60%. And what you can do with these is you can stack multiple tests on each other too. So in this table, which is taken from the Therapy Ed Review and Study Guide, shown in the red boxes are the tests recommended for HIP-OA in clinical practice. The combination of tests for HIP-OA shows good sensitivity, specificity, and likelihood ratios to assist with the diagnosis of HIP-OA. So elements that are included in this cluster are pain with squatting, lateral pain with hip flexion, a positive scour test, pain with active hip extension, and passive hip internal rotation of less than 25 degrees. The scour test, this one's not as useful in isolation, but it does have a positive likelihood ratio of greater than 2, which may indicate that it has a small shift in probability with a positive test. So a different set of clinical criteria for the classification of HIP-OA were developed through a multi-site study by the American College of Rheumatology. And the original form of this diagnostic criteria is as follows. So if you have a patient with hip pain that's greater than 50 years old, who has either hip internal rotation less than 15 degrees and hip flexion less than 115 degrees, or alternatively, they have hip internal rotation greater than 15 degrees, but with pain and morning joint stiffness for less than 60 minutes. That would indicate HIP-OA when it's compared to a radiographic reference standard. This cluster has a positive likelihood ratio of 3.4 and a negative likelihood ratio of 0.19. Based on updated research in the 2017 Clinical Practice Guidelines revision that we're talking about tonight, they recommend revising the range of motion, so just replacing the 15 degrees with 24 degrees, and it's the exact same algorithm, and it performs in the same way. So shown in the figure on the left, that's the hip grind or the scouring test, which is used to identify general hip joint pathology and HIP-OA. So you can see from the picture, the patient's supine with the hip flexed and adducted to the limit of the movement, and then the hip is moved to abduction while maintaining flexion, and a compressive load may also be applied. And a positive test is going to reproduce the patient's familiar pain. Shown in the figure on the right, we have the Patrick's test or the Faber test. In this one, the patient's hip is flexed, abducted, and externally rotated so the foot's resting just above the knee on the opposite leg. And the leg is slowly lowered towards the table surface. And a positive test is when the involved knee is unable to assume a relaxed position and or there's reproduction of a patient's painful symptoms. If you're looking for symmetry, you may also measure the distance from the lateral knee to the treatment table or to whatever surface you're kind of examining the patient on. That can make it a little bit more objective. All right, so there's many interventions available to PTs when they're rehabbing patients with HIP-OA. So for this presentation, what we're going to focus on is those interventions that were rated as having either A, level or strong evidence, or B level moderate evidence in the clinical practice guidelines. And the practice guidelines, they're pretty purposeful about the language they use. They use the language that you should be doing these things in patients that have hip OA. So first thing, muscle weakness, very common physical finding in patients with hip OA. So for patients with mild to moderate hip OA, PT should consider utilizing range of motion and flexibility exercises, muscle strengthening exercises, and aerobic conditioning or endurance exercises. And based on the best available evidence, the exercise frequency should be 1 to 5 times per week for a duration of 6 to 12 weeks. And aerobic exercise may also provide additional benefit when it's combined with stretching and strengthening. There's also some evidence to support including manual therapy to improve range of motion and reduce pain in the treatment of patients with mild to moderate hip OA. So techniques that have shown benefit include soft tissue mobilization and both thrust and non-thrust manipulation. Based on the best available evidence, now for manual therapy, frequency should be 1 to 3 times per week for a duration of 6 to 12 weeks. Now, patient education is often overlooked and should be included in the overall patient management. In patients with hip OA, they should be educated on modification of activities, well-tolerated general exercise programs, and weight reduction if that is an issue, and also on loading methods. Now, systematic reviews and randomized control trials, they're really great at providing clinicians what to do, but they're not always that good about telling you and giving you enough information about how to do it. And that goes for the clinical practice guidelines as well. Case series and RCT study protocols, those are two types of publications that can assist you in applying new clinical practice techniques to your patients. So in this case series of 15 patients with hip OA, a protocol-based regimen of manual therapy and exercise was used, and it resulted in clinically meaningful improvements in pain, function, and range of motion that were maintained at 6 months. The manual therapy interventions were delivered during 10 30-minute treatment sessions over an 8-week period, so that's consistent with the clinical practice guidelines, and consisted of manual muscle stretching, thrust and non-thrust manipulation techniques. And the PTs were permitted to vary the performance of each of the techniques to maximize the benefit, but all the techniques had to be performed on all the patients. 2 of the techniques that were used are shown. They're the hip flexion with a caudal glide mobilization and an internal rotation with a distraction mobilization. Patients were given a home exercise program that reinforced the manual therapy treatment and consisted of both stretching and strengthening exercises. And so some examples of those are for the stretches, the knee to chest stretch and the hip flexor stretch. And strengthening included side-lying hip abduction and bridging. So there's a PubMed link at the bottom of this slide that has the open access version of the paper and also has descriptions for all the manual therapy techniques and exercises that were utilized in the case series. So you can go back and refer to that. So if you want to know a little bit more about the manual therapy techniques and if there was something different from what you were presented in school. All right, so now let's move on to the non-arthritic hip joint pain guidelines. So again, there's an older version of this, and then there was recently a 2023 update it's pretty consistent, but it added a little bit more strength of evidence to some of the things that were discussed in the previous practice guideline. So what are we working with here? Non-arthritic hip joint pain is going to be multiple conditions. So we have femoral acetabular impingement, or I'm going to refer to that throughout now as FAI. Too much words to say repeatedly. Acetabular labral tears or labral tears, and then structural instability, chondral lesions, and ligamentum teres. Diagnosis of this is fairly difficult. It's mostly based on a combination of clinical examination and imaging findings. But for the purpose of this discussion, we're going to focus on the 3 of FAI, labral tears, and structural instability. So FAI may be of a cam or a pincer type. We're going to go over that here. Cam deformity are more likely in males versus females, twice as likely, while pincer lesions are more common in middle-aged active women. Research on FAI demonstrates that the resulting abnormal movement of the hip may lead to labral tears and cartilage damages, and ultimately leads to hip OA. Now, labral tears may be the result of an acute traumatic event or may have more of an insidious onset. They have a prevalence of 22 to 55% in patients with hip and groin pain. And those who subject the hip joint to repetitive stress in sports such as hockey, those are at increased risk for labral tears. Hip instability. This is defined as an extra physiologic hip motion that causes pain with or without the symptom of hip joint unsteadiness. Kind of a mouthful there. The main risk factors are shallow acetabulums, also known as hip dysplasia, excessive femoral anteversion. And the prevalence of hip dysplasia is about 5 to 35% in patients with hip pain. And in more severe cases, there appears to be a genetic predisposition to it. And so here are the two types of FAI. So on the left, we have CAM type lesions, where there's insufficient concavity of the femoral head neck junction anterior laterally, and it results in a pistol grip or a head tilt deformity. Some associated pathology includes separation of the adjacent acetabular cartilage from the subchondral bone and shearing of the labrum and or avulsion from the rim. On the right is a pincer type lesion, where in this there's over coverage of the femoral head by the acetabulum, which leads to linear contact of the labrum against the femoral neck during regular physiologic hip motion. The labrum eventually fails first from the repeated trauma and may either ossify, which actually worsens then the overcoverage, or it forms some sort of like an intrasubstance ganglion. So this is what pincer looks like on radiographs. I'm not going to get into too many of the details of reading these. I think it's kind of beyond the scope of this, but just to give you kind of an idea of what it looks like. On the left is an AP radiograph, which shows bilateral pincer deformities with an associated crossover sign. So that's what you might hear either in radiology reports or you might hear in discussions with other providers. So on the right, we have an expanded AP view of the right hip, and the anterior rim of the acetabulum is marked by the white dots here. The superior portion, and while the posterior rim is marked by the black dots here. So the superior portion of the anterior rim is going to lie lateral to the posterior rim, showing by the white arrow, and that indicates overcoverage of the acetabulum. So anteriorly, it assumes a more normal medial position, which creates the crossover sign, which is shown by the black arrow, and that indicates, again, pincer impingement. So here's CAM impingement. On the left is a frog leg lateral view of the right hip. The CAM lesion is shown in the green arrow right here. Which is evident as a convex abnormality at the femoral head neck junction, where there should be normally a concave slope of the femoral neck. So the femoral neck should be more kind of curved, concave in that position there. Surgeons may also evaluate something called an alpha angle that's used to quantify the severity of the CAM lesion, but that's definitely beyond the scope of what we're talking here. One key point to remember, just as in the lumbar spine, asymptomatic individuals might present with radiographic pathology. So in a study of 63 asymptomatic volunteers and 63 patients with symptomatic FAI between the ages of 20 and 50 years old, a defect of the articular cartilage and or the labrum was present on average in 57% of asymptomatic volunteers compared with 80% of symptomatic patients. So of course, symptomatic people have more, but there's a lot of people that are asymptomatic that also have these defects. So just a lot of times, if there's don't treat the pictures. And when you do examine patients, if they do have radiographs and MRI, make sure you do the physical exam first and look at the MRI or the X-rays second. So as with hip OA, it's important to also assess self-reported function and physical impairments. The recommendations are very similar as what we previously discussed. So there's just some slightly different patient self-reported outcome measures. So in patients with non-arthritic hip pain, it's important to assess passive range of motion, particularly internal rotation, external rotation, flexion, extension, and hip muscle strength. Again, particularly hip abductors and external rotators. The special tests are a little bit different. Some useful ones in non-arthritic hip joint pain include the Faber and Fader tests. And we'll discuss more elements of the physical exam here in subsequent slides. Also important to assess physical performance. These tests should be used at baseline and at least one other follow-up point. And you should choose the test based on the functional limitations and requirements of the patient. And some of the things that you can consider include the single leg squat test, the star excursion balance test, single leg hop for distance, and or the single leg sit to stand. Again, some of these non-arthritic hip patients are usually a little bit younger than hip OA patients. And I saw a question in the chat that I'll definitely get to once we finish up the questions, the exam questions here at the end. But obviously you wouldn't want to have like a 70 or 80-year-old individual doing like a single leg hop for distance. So, but they do not typically have non-arthritic hip joint pain. They're typically having more of a hip OA. So as I stated previously, within non-arthritic hip joint pain, there are multiple conditions. We're going to focus on FAI, labral tear, and structural instability. All of these categories, they might report anterior lateral hip joint pain. Now, patients with FAI, to differentiate these, may have increased pain with sitting. They might have a positive fader test and may have mechanical symptoms such as catching, locking, or clicking. A negative fader test is pretty useful to help rule out FAI, but you need to use the positive test in more of an overall clinical exam sense. And patients with labral tears may also have similar symptoms, but may not have the limited hip range of motion that you're going to see in FAI. Patients with structural instability, they may have a positive apprehension sign, pain with a fader or Faber test, and they also have mechanical symptoms. Hip internal rotation range of motion, that can help differentiate FAI from structural instability. So when you measure hip internal rotation at 90 degrees of hip flexion, patients with FAI are going to display hip internal rotation of motion less than 20 to 25 degrees, while patients with structural instability display greater than 30 degrees range of motion. So think about for a second, what's the location of symptoms for hip joint pain? What have you been taught? Traditionally, it was described as a deep anterior groin or hip pain, but more recently, authors have proposed the C sign to describe this type of joint pain. So in the C sign, the hand is cupped above the greater trochanter with the fingers gripping the anterior groin, as you see in the picture here. So that is the C sign. Again, hip joint symptoms that may also be referred to the medial thigh or knee or in the anterior thigh region. Shown here in the red box is the best test for labral lesions and or hip weakness. So the flexion, adduction, internal rotation test, what we're calling the fader test, that's the only one that's available for hip labral lesions. As you can, that's really useful. As you can see from the likelihood ratios, that's not super helpful in the diagnosis of labral injuries, a little bit more sensitive than specific, so the negative result is a little bit better. The Trendelenburg sign is a better positive likelihood ratio than negative likelihood ratio, and a positive test is going to produce a moderate increase in the probability of a diagnosis of hip weakness. So here's how you do those two. Shown in the figure on the left is the fader test. With the patient supine, the involved hip is moved from full passive flexion, abduction, and external rotation into a flexed, adducted, and internally rotated position. And a positive test is reproduction of pain, and patients may also may report a click with this test, a painful click. Performance of the Trendelenburg sign is shown in the figure on the right. And so the patient's asked to stand on one leg with the opposite knee flexed, and a positive test is when the hip and pelvis drops when the lower limb support is removed. And that indicates weakness of the hip abductors on the stance leg. So this hip drops, the weak abductors are here. The strongest evidence for non-arthritic hip joint pain includes a multimodal interventions, and you can see the ones that are listed there. So all the treatment plans should include activity modification and strengthening exercises, specifically for the hip, but also including other lower extremity muscles such as the quads and hamstrings. Hip weakness should be addressed with progressive muscle strengthening exercises, with particular emphasis placed on the hip abductors and external rotators. And this emphasis should be increased in patients that have structural instability because they need to have more stability, that active stability. Aerobic conditioning exercises could also be utilized to optimize health, although the modes of exercise that increase pain should be avoided. So some hip-friendly aerobic exercises include cycling, swimming, and elliptical machines. So your additional interventions, they may include manual therapy, posture movement correction, stretching, and balance exercises. Manual therapy may be beneficial to reduce pain and improve range of motion. And in patients with FAI, end range, physiologic flexion, adduction, and internal rotation techniques should be avoided because they tend to increase symptoms, and you can't stretch through kind of these bony blocks that we describe in patients that have things like FAI. There's weak evidence to support movement pattern training, which is kind of that posture movement correction, where the patient's coached to avoid painful lower extremity movement patterns during movements such as squatting. So there's also weak evidence to support therapeutic exercise alone that includes joint mobility, muscle flexibility, and strength exercises. And then patient education should focus on a couple things. Activity modification is one, and then kind of managing pain is the other one. All right, there was an RCT published in 2018 that compared surgical versus non-surgical treatment for patients with FAI. There was no significant difference between the two groups, and 1/3 of the military patients were not medically fit for duty at 2 years. And the results are shown in these two figures here. But one of the main limitations of the study was the high rate of crossover. So only of the 40 patients who were randomized to receive rehabilitation, 28 eventually ended up undergoing surgery. So the kind of crossover was a huge problem in the study. But this information is from the study protocol that was published and is available open access at the link on the slide. Again, just like the other one. And so shown on the top left is the clinical reasoning that was used in choosing the manual therapy techniques. I think this is a good kind of overall kind of how to do it type of paper. So for example, if on an exam, a patient reported pain with internal rotation motion, a technique that was chosen was the internal rotation mobilization with movement. And however, if on the exam the patient reported pain with the quadruped rock, a technique was chosen was the quadruped lateral hip distraction mobilization with movement. So here's the internal rotation mobilization, and here's the hip flexion mobilization. So the exercises that these researchers chose were prescribed. They were directly reinforcing the manual therapy techniques, and then general hip strengthening exercises were also incorporated into the treatment plan. All right, so now that's the didactic portion. Let's transition into some of the review questions. So let's see. The way that we do this, we use a poll. I'm going to launch the poll here. You guys should see it. So what I'll do is I'll flash up the question. I'll give you guys about a minute or two to put in the answers. Go ahead and put in the answers on the poll. And then we'll go over the rationale for the question, kind of some key things to look at, and then kind of the answers, both the correct ones and the incorrect ones. So here's the first question. So take a minute or two, read through the question, and then put in your answer, and then we'll start discussing. Give everybody a little bit more time here. All right, so I think I'm gonna end the poll and share the results here, so you guys should be able to see this. So most people chose D. So let's look at the question first. So highlighted in the red are some of the key points from the question. So obviously we're looking for a self-reported outcome measure. We want the one that's the most valid and reliable, and the condition that we're looking for is hip OA. So the correct answer was D, the WOMAC. So again, the WOMAC, widely used. Three subscales: pain, stiffness, and physical function. Scores range from 0 on the items. Each item is graded from 0 to 10, or alternatively could be from 0 to 4 if it's a Likert scale. But higher scores are more pain, disability, and stiffness. So if the start bat or the start um, and the modified Oswestry Disability Index, the ODI, those are both utilized in patients with low back pain. And so the START tool that attempts to stratify patients into low, medium, or high risk categories. And then the ODI is just a valid and reliable measure of self-reported function in patients with back pain. And then, of course, the lower extremity functional scale, also an outcome measure that could be used in the hip. But again, this is very common on board questions. The WOMAC is the best answer, but you could use the LEFS as well. All right, so I'm going to relaunch the next poll. And here's the next question. Take about a minute or so, minute to 2 minutes, and then we'll go over the answers. Give everybody about another 30 seconds or so. All right, here's our results. So most people chose answer B, morning stiffness after awakening. So let's take a look at the question. So key things, we want a clinical sign or symptom, and we want diagnosis of hip OA, but less likely in patients with FAI. So we're going to differentiate between hip OA and FAI. And I think you guys got it exactly right. You're killing in these two questions. So morning stiffness is typically associated with arthritic conditions. So it doesn't have to be hip. It could be any arthritic condition, but they're usually stiff in the morning, while patients with FAI are more likely to report pain with movement with activity. So one other thing to consider with differentiating like OA from anything else too, like there's different or arthritis, there's different types of arthritis. Remember there's your osteoarthritis versus your inflammatory arthritis. So your your things like hip OA, knee OA, that's your osteoarthritis. And they tend to have pain and stiffness in the morning for 30 to 60 minutes or less versus those that have pain for longer than that, like 2 to 3 hours, so longer than an hour. That's typically an inflammatory arthritic condition. Things like rheumatoid arthritis, think about with those. Some of the incorrect choices here: limited hip internal rotation, range of motion, pain with hip internal rotation movement, and deep anterior groin or hip pain. Those are all signs or symptoms that are kind of consistent with both of them. All right, so now we're going to relaunch again. We have two more questions, 3 and 4. So go ahead and take a look at this one. And go ahead and put in your answer whenever you're ready. We'll give you a minute to 2 minutes here as well. Give you another 10 or 20 seconds. All right, so here's what we got. We got about 3/4 chose A and 1/4 chose C. So let's look at the question itself. So the hip pain that we have is chronic. And again, we want to differentiate FAI from hip OA, but we're kind of reversing it this time. We're looking for something that's more consistent with hip OA. I'm sorry, femoral FAI versus the hip OA. So what of these was more consistent with FAI? Was exactly A, was mechanical symptoms. So again, FAI is that big category of non-arthritic hip joint pain. So you got to use just a combination of imaging and clinical findings when you're making these diagnoses. But you can suspect, excuse me, you can suspect FAI with the following clinical and radiographic findings. So anterior groin or hip pain that's reproduced with some of these special tests, the Fader or the Faber test, the hip internal rotation range of motion that's lost, and mechanical symptoms. So then you're popping and snapping, and then you may have some imaging findings as well. And so all the other ones there, they may also be associated with hip OA. So I'm gonna answer this one real quick because it did come up in the chat. Is that the report of anterior lateral hip pain is FAI as well? Yes, it is. But that is also a complaint in hip OA, so it doesn't necessarily help you differentiate between the two. Patients with hip OA rarely say that they have these kind of mechanical popping and snapping type symptoms. So that's the big differentiating factor there. All right, one more question, and then I'll take questions from you. So here you go. Go and put in your answer choice, and that could take about a minute or two. All right, I think we've got most people that wanted to reply, so let's see the results. Most most people chose D, manual therapy, but there was some that chose aerobic exercise. So let's go to the question. So one of the things here I think we want to look at is mild hip OA, not severe, so mild to moderate. And then we're looking for a technique to reduce pain and improve range of motion. So those that chose D were correct. So manual therapy. So that's from what I presented on the clinical practice guidelines. There's pretty strong evidence to support manual therapy to reduce short-term pain and improve mobility and function in patients with mild to moderate hip OA. So not severe though. And so you can include the choice of what you include is really, I think, left up to the clinician, both thrust and non-thrust techniques, and then soft tissue mobilization. Dosage, 1 to 3 times per week over 6 to 12 weeks. And then as hip motion improves, you should add exercises, including strengthening to augment and sustain gains in the patient's range of motion, flexibility, and strength. So I think always remembering that manual therapy is an adjunct treatment. You would definitely, you know, the gains can be short term. So you want to make sure that they're doing exercises to reinforce that and make sure that they're maintaining the gains that you get with a lot of the manual therapy you're doing. All right. So the other ones are okay answers, I think. So balance training, that's something that you could include. Aerobic exercise, you could include. There's not a lot on dry needling at this point, but it wouldn't be like contraindicated. But I think of the choices here, manual therapy is obviously the best answer. But balance training, particularly in aerobic exercise, those could definitely be included in a program. So with that, that's all I have for you guys. I'm going to take your questions. Just if the best way to do this is if you would just type your question into the chat. What I'll do is I'll repeat the question and then yeah, hopefully if you want to follow up, just kind of do that in the chat as well. So first, I had a couple questions during the presentation. One, just thinking about age for FAI. So age is younger. So you're looking at younger to middle-aged patients. So I'll go back to the slide that has that on it. I think it's this one right here. So looking at age, kind of middle age is 30 to 40 years old. I don't really have a number mixed on the slide, but both from clinical experience and a lot of the research that you'll read, you're mostly looking at middle-aged people. Pincer lesions are the most common in middle-aged active women. So I don't know why there's a difference between men and women in the types of FAI lesions, but there definitely is in the research. And then the other question there was, so I said that mild to moderate OA, you would want to do like manual therapy, exercise, those type of treatments. Once you get to severe OA, then you're talking kind of injections and joint replacements are probably more effective for severe OA. Our type of things that we do as physical therapists become less effective once the OA in the hip gets to that point. But that shouldn't preclude anyone from making an attempt at rehabilitation in a patient with severe hip OA. So next question, it says, for question 3, I took the popping to mean crepitus. What wording would be used to describe crepitus if not popping? That is a good question. So I don't, crepitus, I think is more of like a kind of a sandy, grindy type of sensation that I would think, and I think the popping is more of like if you think of like a bowstring or a guitar string, it's more of a single type of pop. It's not a continuous type of like pop, 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 like you get with an arthritic joint. So that would be the difference. Now, as far as how that's described on a question, that's good. I don't know that I really have a good answer. Crepitus and popping are kind of the same thing. But I guess clicking is one that you would think of. As far as more of a mechanical symptom. So I'd say maybe, yeah, if you'd say more clicking than popping would be the word that I would describe. Next question is, could I briefly go over the star excursion balance test? And so if you're familiar with the Y balance test, it's the same thing. So if the way I describe it to patients, if you think of the cardinal directions as like in terms of your body, or if you say facing forward, that's north, and backward is south, right is east, and left is west. So the star excursion balance test just asked the patient to stand on one foot and reach as far as they could with the opposite foot in each of the 4 cardinal directions, north, south, east, and west. But then also the diagonal position. So northeast, southeast, southwest, northwest. What they found over time was that the eight reaches weren't really that necessary. The most information came from the anterior reach, so towards the north, and then the southeast and the southwest direction. So that became the Y balance test, but it's actually just the same thing. One thing to consider with that test, there is a huge learning effect, especially if a patient has never done it before. So you really do need to let them practice quite a bit because they'll start to get better over time as they do it. And you don't want to mistake the fact that they're getting better at doing the test with improvement in their actual condition. So that's one of the things that you want to think about with the both star excursion test and then the Y balance test. You may see the star excursion test called the modified star excursion test, and that is again, that's just the Y balance test. They're the same things. So hopefully that makes sense. All right. Again, I'll take any questions you guys have. They don't have to be necessarily related to the presentation today. Uh, Yes, so total hip, good question. So the question here was, would you be able to go over total hip replacement precautions for both approaches? Um, Interesting, because I mean, I just changed the textbook for next year, the therapy ed study guide for next year. So let's talk a little bit about like hip precautions. You may see surgeons like, so I think from a clinical practice perspective, every surgeon that you work with is going to be very different. So just make sure that you're checking with them. Some of them don't even use hip precautions anymore. I don't know how many, but generally, let's see here. Let me pull up what I put for the newest study guide. Uh, yeah, so your typical approaches are your anterior lateral and your kind of posterior approach. Um, So the most common that you're, sorry, anterior and posterior lateral, not anterior lateral. So posterior lateral and then anterior. So if you think of what is posterior lateral, that's when I was talking about the rotator cuff of the hip and the deep rotators. Those are the things that we're talking about. So with those, with a posterior lateral approach, which is still the most common, you want to, the one that you majorly want to avoid is flexion, adduction, and internal rotation of the hip, because that's going to stretch and strain those muscles that have been resected so that you could put a new hip joint in. You want to avoid flexing the hip more than 90 degrees, crossing their legs or feet, and pivoting inward or internally rotating on the surgical leg. Now, if they have an anterior approach, you want to avoid extension and external rotation. So kind of think if it's on the backside, you don't want to bring them to the front. So you don't want to do flexion and then also adduction, internal rotation. And if they have a front side approach, you want to avoid extension and external rotation. So some of the other kind of movements that you would want to talk to a patient about, don't cross your legs. That's a pretty, that's consistent between both of them. Don't pivot outward on your surgical leg, so turning into the external rotation. You don't want to let them go into external rotation. And then if they're side lying, you want them to sleep on the surgical side versus if they're posterior lateral approach, you'd want them to sleep on the other side. All right. All right. So next question was just some insight as to within the intervention section of the study guide, the review and study guide, a lot of the interventions look the same. Some version of resistance training, range of motion, manual therapy, etc. Um, do I have any insight into which conditions would be good to focus on that are different or stand out in my mind? I do think so. That's where I do think the clinical practice guidelines do come in. If there is, because a lot of it looks the same because there's not a lot of evidence for some of the conditions that we have. Most of the high volume conditions now we do have clinical practice guidelines for. So I think if you focus on the conditions that have clinical practice guidelines and knowing what is the best evidence currently for those conditions, I think that would be the best way to go at that. And that's kind of why we added the clinical practice guidelines to it, because if you look at a big textbook, orthopedic textbook, so we use the Dutton textbook where I'm teaching, it's there's a lot, right? It's very hard to know exactly what to do. And as you get to clinical practice a little bit more, you'll figure that out. But at the same time, that doesn't help you when you're getting ready to take the test next month. So I would definitely focus on the clinical practice guidelines. Hopefully that helps. All right. Any other questions out there? If not, we're a little bit after 8. So thank each of you for your time. Appreciate you joining. Hopefully you got something out of today. And good luck those taking the exam in July. Best of luck to you guys. And if you're taking your exam later, these sessions will run every week, and hopefully get your study in focus. So thank you and have a good night.